name is Routine and I am a student nurse. So for today, I will demonstrate the emergency management for prolapse of umbilical cord. So first thing I will do is I will gather all the items that I will need during the procedure. For the procedure, I gather all the items that I need for the internal examination and prepare for double setup. For internal examination, I need clean gloves and lubricant. For vaginal delivery, I need 2 sterile gloves, 1 straight forceps, but I don't have, so I'll just say what is available for me. 1 Mayo scissors, 1 urinary catheter, which is not available also for me, 1 placental basin, 1 needle holder, 1 sterile gauze, 1 syringe with needles, 1 chromic optional, 2% lidocaine and it's also optional, and cotton balls with betadine. It is important to prepare all the items needed for easy accessibility for the inspection of the external genitalia, vagina, and cervix. Hello, good afternoon. My name is Routine and I am your student nurse. Identify the client, introduce yourself, and explain the procedure. It is to obtain the client's cooperation and work simultaneously. To assess the progress of your labor. Is that okay with you? Okay. So, may I know your name, please? Can I check? Okay. So, Fede. May I know your date of birth? Okay, June 1, 1976. So, Fede, what name do you prefer me to call you? Okay, Fede. So, Fede, during this assessment, you will feel a little bit
after interjection, you can close the curtain and close the door to give privacy to the patient and also to maintain the dignity of the patient.
1 to 10, and 10 is the highest. What is the rate of your pain? Okay, 5. So, first I will check your blood pressure.
It is important to document your initial assessment data for the patient, including fetal heart rate activity, the baseline fetal heart rate, long-term variability, acceleration and deceleration, and maternal vital signs. This includes blood pressure, fetal heart rate, vaginal examination, if the prolapse cord, what time, to palpate the uterus, and also assess lung sounds, heart sounds, pain assessment, and access IV site if there is no redness, swelling, infiltration, bleeding, or drainage. Dressing is dry and intact.
Okay, so your blood pressure is 134/80. So let me check your temperature. So I will put it here for 5 minutes. And can you give me your index finger, ma'am? Heart rate is 87 beats per minute.
The patient will be positioned on the examination table to check for the progress of her labor. So you can position the client in dorsal recumbent position, Sims position, or knee chest position. The aforementioned positions are made best so as to expose the gynecologic area to be examined. Position depends on client's capability and examiner's preferred position. Ma'am, I will put the drape on you and will expose the part that I only need to assess.
So ma'am, you will be positioned on the examination table.
I will do hand washing, then I put on examination gloves for the internal examination, and I will change into sterile gloves after I assess the progress of labor.
So please, I will just position you where you can just move a little bit, and lower extremities will be flexed and rotated outward. When I do the anal examination, please take a deep breath while I'm inserting my 2 fingers, okay?
Assess the well-being of the pregnant woman if the cord is visible outside of the vagina,
Okay.
or can be filled in the vagina below the presenting part. Handle the cord carefully. Do not pinch the cord. On inspection, the cord may be visible at the vulva. And to assess the cord for pulsation, after performing examination, assess the well-being of the fetus or check the fetal heart rate.
Once again, I will check the fetal heart rate by checking your abdomen.
Assess the mother to do a knee test, held tilt left lateral position, and instruct the mother to take the deep breath and control the urge to bear down. Elevate the presenting part by filling the urinary bladder by inserting a catheter. Instruct the client not to bear down. If the decision to deliver interval is likely to be prolonged, particularly if it involves ambulance, transfer, elevation through bladder feeling may be more practical. Bladder feeling can be achieved quickly by inserting the cut end and the intravenous giving set into a Foley's catheter. The catheter should be clamped once 500 to 75 ml have been instilled. It is essential to empty the bladder again just before any delivery attempt, either vaginal or cesarean section. Elevate the presenting part by inserting your fingers into the vagina and push the head of the fetus upward. Do not remove your finger until you arrive at the operating room or by instruction of the obstetrician. Elevation of the presenting part is thought to relieve the pressure on the umbilical cord and prevent mechanical vascular occlusion. Manual elevation is performed by inserting a glove or 2 fingers in the vagina and pushing the presenting part upwards. Excessive displacement may encourage more cord to prolapse. To prevent vasospasm, there should be minimal handling of loops of cord lying outside the vagina. Call out the time of birth and gender of the baby. To safeguard mother and baby against infection and to facilitate spontaneous breathing of the infant. If the newborn is with good cry, we'll proceed with EINC. If it is not crying, we'll cut the cord and resuscitate the infant if needed. EINC means essential intrapartum and newborn care. After the procedure, you will remove your gloves, wash your hands, and document the time, date, and the procedure. So for documentation, beginning vital signs, the blood pressure is 34/80, temperature is 37.2, and the saturation level is 7 beats per minute. Fetal heart rate baseline was 110 with variable deceleration and drop at 80 beats per minute, not reassuring heart rate. The vaginal exam prolapse cord at 315, palpate uterus tone was moderate between contraction. Contractions were regular with a moderate intensity. Contractions were approximately 4 minutes apart and lasted 50 seconds. Clear and equally bilateral, the lung sounds. The heart sounds are regular with the murmurs. Pain assessment, yes, some pain, rate of 5. For the IV side, no redness, swelling, infiltration, bleeding, or drainage. Dressing is dry and intact. For the oxygen treatment, 100% oxygen, non-rebreathable mask. Administered 0.25 mg terbutaline sub-Q, 500 ml bolus lactose drenchers given over 60 minutes. So the fatal baseline was 110 beats per minute and then dropped to 80 beats per minute. FHR strip showed variable late deceleration that progressed to prolonged deceleration. So I believe the baby is in trouble and mom needs to be evaluated immediately. So this is my assessment for today. So cesarean section is highly recommended. So once again, this is Analisa Gumban Routine, Bachelor of Science in Nursing, Penma University of Iloilo, for the demonstration of emergency management for prolapse of the umbilical cord. See you. Bye-bye.